weight. We know that the hip connects the axial skeleton, which is made up of the rib, the upper trunk, and connects it to the lower extremities, thereby transferring weight bearing. And in this weight bearing, there is also weight transfer. The combination of these two facilitates, the combination of these two shows in movement, which is actually the function of the hip. Then rehabilitation following hip arthroplasty aims to restore the movement and the function. Those are basically the two main functions, the movement and the function. The movement is actually the function of the hip joint. So it will be used interchangeably, that I can say movement function, because basically when the weight is transferred, the activities of the muscle at these hip joints, whether it's propelled in any direction, because it's polyaxial joint, it moves in different directions. So we can get a movement, and these movements are the function. So the relevant anatomy, like I said, I won't go into the surgical aspects of this. I will just keep it to what I am presenting on. If you look at the joints, we know that the hip is a ball and socket joint. The ball being the head, the socket being the acetabulum. So there are other soft tissues that, the muscle, the ligaments are connected, thereby helping. Then the acetabulum helps a whole lot to stabilize the hip, because the depth contains, unlike the shoulder joint that is shallow, the hip joint, the acetabulum functions in stability. Then I will go to the one that concerns me more, the muscles. The muscles, there are 25 muscles acting at the hip. They are grouped into 6. We have the flexors of the hip, the extensors of the hip, the abductors, the abductors, then we have internal rotators and the external rotators. Those muscles, whenever there is a surgical procedure, whether it's hip replacement or any surgery that pertains to the hip, whether fixing of any hip surgery, there is always a compromise. Studies even show that any surgical procedure into the hip decreases the strength of the muscles acting at the hip by 50%, meaning that the muscles acting at the hip joint are functioning submaximally whenever there is surgery. You know, when we talk about surgery, we are talking about, like, when we even talk about this 50%, we are talking about patients that are young, that are mobile, and that are using the muscle. But when we talk about the older generation, those ones, some are confined to wheelchair because of severe osteoarthritis. So when you have this type of patient, the conditioning that is already happening
I think we lost her for a bit. We'll just wait for the network to get better. Hopefully it's not my network that's bad. We did lose her. We'll give it a minute and I'm sure she'll get back on. You're welcome back, isn't it?
Can you hear me now?
Yes, I can. You're welcome back.
Sorry about that. The connection went off. Yeah, no, but I'm back. I was talking about the muscles which are attached to the hips, the hip joint. Like I said, the six group of muscles which are attached to the hip, functioning directly or indirectly in bringing movements in different directions, the polyaxial movements to the hip. So I mentioned that we sometimes concentrate so much on the normal, total, or partial hip replacement, forgetting about revision arthroplasty. Those ones, they come down with deconditioning more than the first two I had mentioned before. When we talk about revision, it might have happened from aseptic loosening of the implants or prosthetic infection. Those ones, they've been immobilized for some time before coming for review. So when the plan is to do two-stage rehabilitation, there are things that the patient can do. We have a case in the ward now who is undergoing bilateral hip replacements, revision, bilateral hip replacement. And the man, when he came, when I did an assessment with him, his goal was that the least he could get out of this hospital is to work with bilateral axillary crushes. This is a man that has not been working for more than a year. So I started talking with him. I got to find out that the joints, all the joints, I'm not talking about the hip joints, I'm talking about even the upper limb joints, the shoulder, the elbow, the wrist joints, the grip strength is poor. The bilateral shoulder glenohumeral joints, the muscles acting on those joints are weak. So even if we have a plan to start mobilizing him when he had undergone the first stage and second stage, these muscles, he cannot even stand. We're not talking about the weak core muscles. So I told him that if we have to go through this stage, it has to be that before the first stage, we will establish a pre-operative program which will take care of, at least we will get to muscle strength of 3 to 4 for the upper limb, so that we can be able to hold on to the crutches or any walking aid. We started working on that. He had his first surgery, which is the first stage. But we started training the hip muscles. We started working on the quads, the muscles acting at the knee joint while he was seated. Because, like I said, bilateral, two of the formerly replaced hip, they became infected. He's a diabetic patient, so he became infected and he just went down from there. So he had muscle wasting. He had reduced range of motion at the bilateral hip joints and weakness. So we started working on that. He did the first stage for the left, did the second stage for the right, then he did the second stage. We now started standing. But we couldn't have done that if he had not undergone the pre-operative stage, which helps to work on his fitness level, the cardiovascular endurance, then share this. This is the pre-operative physiotherapy. It's advised that if you have a patient that is supposed to undergo hip replacement, it's advised that if you have a patient that is supposed to undergo hip replacement, invite a physiotherapist to do an assessment. This assessment will reveal some things that normally, if you concentrate so much on the hip replacement, you won't even find out. No offense, it's just because if we concentrate so much, you won't know that the patient actually needs the upper limb to walk. yes, if he's going to use walking aids, he will need to have strong grip strength to be able to do that. So it helps. Then when we talk about the building of the cardiovascular, cardiorespiratory fitness, we can give patients some of upper limb cardio workout, cardio exercises, breathing exercises, can even give the patient an incentive spirometer to be blowing repeats 100 to 50. This will help to prepare the patient for the post-op. Then when you introduce the pamphlets or the guideline or the protocol, which the patient will go, or the stages, when the physiotherapist starts talking to the patient about the stages post-op, there is this confidence level that will come over the patient, and we have a goal. What is the goal? Is it to sit down? Some people, its goal is actually to sit down without pain. But some people, most of the patients here in Nigeria, is to be able to walk. Whether that walking is by using walking aid or but to be able to move from one point to another without using wheelchair. So you will get to find that out. Then you design a program. The patients must not come for outpatient physio every single time or every day or even weekly for pre-operative. We can design a program where you give the patient the regimented exercises to do at home. And you may be concerned and say, what if the patient has pain? There are exercises that will not lead to pain. Isometric exercises when a patient is seated will not lead to pain. ROM range of motion exercises, which will not, we can encourage patients to do it as tolerated. So there is no need to inflict more pain on a patient that is already in pain. And again, we noticed that even studies suggested that it decreased pre-operating physiotherapy, decreases the length of stay for the patient at the hospital. It deals with the anxiety level. So now we go to here, we are starting that, assuming that the surgery has been done and everything is in place. There are precautions we educate patients on. Patients should not cross the thigh on the knee. Why would you say so? Sometimes, most of the patients, this actually is very important for some patients. Most of the patients are not exercisers. So their muscle integrity, you can't compare it with an athlete. An athlete might be able to get away with something, but because of the level of high integrity muscle, but somebody that has been deconditioned, somebody that has had decondition due to pain and is not utilizing the hip as it should be, should make sure to adhere to these precautions. One is not to cross the legs. When they cross the leg, they put the hip in varus. That's like pushing. It can lead to dislocation. Depending, it can lead to dislocation. And when you start reducing it, a replacing, you are injuring the vessels and you are injuring the soft tissue around. It becomes, and it can happen. Once it starts happening, it starts repeating itself. Then you educate the patient on why. We also educate them on the patient should not flex the hip less than 90 degrees. Again, this one is depending on the approach, but to be on the safe side, the approach, I mean the surgical approach, whether it's direct anterior, whether it's Watson Jones, anyone, but to be on a safe side, the patient is advised not to flex the hip. When you sit, and this goes with sitting on a low surface, when you sit at the low surface, you will realize that your hip is flexed more than your knee. So that puts the hip flexing less than 90 degrees, and it can cause dislocation for somebody that has posterior approach. So internally rotated, again, it puts the hip in valgus. We will prefer, this is not surgical positioning. I'm just trying to use it as an example, how the hip will look like. And the same thing with most of when the surgery is done, we advocate that the patient use abductor pillow. These are the precautions. Then avoid sitting on, as I've mentioned before. Then the driving, this for the first 6 weeks, so that the hip will be able to heal and the patient can return to driving again. Ambulating general weight bearing as tolerated. If there is no indication or no advice against that from a surgeon, we start the patient with as weight bearing as tolerated. Again, I mentioned the patient's advice because it's the surgeon's advice because it's the surgeon that did the surgery. There might be a case where the bone, I don't want to mention pre-operative fracture or whatever. We can have fragile bones. So when the surgeon says, okay, can we hold on to the weight bearing now? We can do toe touch or no weight bearing at all. These are extreme cases and rare cases. But when the surgery is done, weight bearing as tolerated with any assistive devices, walking aid. So we go to the phases of post-op rehabilitation. There are 4 phases. The first stage, which is the protective stage, the motion stage, the intermediate stage, then this advanced. The protective stage is where you are protecting the surgical procedure. Motion stage, you are getting into activities, but yet you are following precautions. Intermediate, we are returning to the normal activity level of the patient. Then advanced is actually, most patients do not stay at this level. This level, 4th level or 4th phase, is just reserved for sportsmen. Again, when a patient has the dream of returning to sports, we know that this patient cannot go back to high impact exercises, high impact activities. Who is restricted to low impact because you can't bear to put too much load and too much force on the replaced hip, even on the stem and the bone. It can cause splitting. Again, why treadmill is contraindicated in a patient that has running on treadmill. Is contraindicated on a patient that has undergone hip replacement. So the first week, which we say which is labeled the protective stage. Here we allow the healing, the soft tissue, of course, because it's a big surgery, you allow the soft tissue to undergo the process of healing. Here, the goal actually is to reduce, as the patient is medicated and then the healing is taking place, we allow the patient to at least for the swellings to go down. Again, there's controversy surrounding using eyes or not using eyes, again, because the cryotherapy circle has gone from rest, prize, now we have peace and love. So sometimes the eyes, when you use eyes around a healed hip, is just to offer sort of soothing, but it doesn't work on the swelling, just to reduce the pain. Reduce this, but not the swelling. So sometimes people will rather follow the peace and love. Peace and love, meaning that you just start optimal loading, you educate the patient, and that will be that. Some of the exercises you commence in the first week is how to get the patient out of the bed, isometric exercises for the hip muscles, for the quads, and for the hamstrings. Of course, ankle pump. This one is very important because he helps to prevent whether a combination of PE or deep venous thrombosis. So to get the patients in the first 72 hours out of the bed is very important. I know of course, the anticoagulation protocol might be enacted, but again, walking can help. Walking can help to avoid this kind of incident. So when the patient, you've managed to get the patient out of bed after explaining the precautions, again, we make sure that the patient understands the idea that the leg must not cross. That dislocates a lot of hip. And when the patient is old and precondition has already set in, even before the planning for the surgery, is an easy occurrence, even in any hospital, is an easy occurrence because the muscles are weak. Once the patient crosses the leg, the hip pulls out. So we educate the patient even on how to stand up, on how to walk. So when we introduce this, the first stage exercise, the first phase exercises, we started taking care of the muscles that are involved. Then the second stage is where it takes actually the goal as listed below, and it takes from the second week to the 6th week. Here, muscle strengthening for the entire hip girdle. Muscle, all the muscles acting at the knee need strengthening. Where are the ones that was touched or was not touched? At least for the conditioning and for the surgical procedure. If you concentrate on one group of muscle, like you concentrate on the flexors and the extensors, and leave the abductor, you will come down with a patient with Trendelenburg's gait. This is very important, unless indicated otherwise by the surgeon, because sometimes the surgical procedure can actually inform the movements to be restricted or not. But if not, please, you make sure that the physiotherapist understands, or the physiotherapist should understand the importance of strengthening all the muscle. By the time you are taking away the walking aid, you will have patient that is moving or walking without a limb. Like I said, increased range of motion. Make sure that you are still adhering to the physiotherapist is adhering to the precautions, because we still don't want the hip to be flexed less than 90 degrees. Then we continue with the gait training. By then, the patient is moving with either crutches, either Zimmer frame. Most of our elderly patients, we give them Zimmer frame to avoid fall. Fall is another issue. We give them Zimmer frame to avoid fall. I will make sure that they've gotten to a stage where we use the criteria listed out to make sure that they can either go to walking stick or nothing at all, or walk without any walking aid. But there are steps to take this patient through before you can make that decision. And here you introduce bicycle ergometer with progressive increase in resistance. You start sidestepping. Here you start proprioceptive training. Proprioceptive training has to do with training that challenge proprioceptive receptors. Those ones, they deal with balance, they deal with stability and with coordination. Of course, we start training them. There are exercises like that, but within precaution listed. Then we go over to the intermediate phase. Here, a patient is basically walking with one crutch now. In the 7th week, most patients discharge themselves after this phase, because now they are walking. And apart from the walking, if they don't have a limb, which comes from any weakness, we reduce their sections, and from reduction of their section, they will disappear. But it's quite different for a sportsman. A sportsman will have to follow strictly the program, because before he can return to, when I talk about sportsmen, again, I will emphasize that low impact sports persons, low impact. Because like I said, you can't subject a replace hip to high transmission of force and high transmission of weight. It will break down. Micro trauma will set in, and once that micro trauma sets in, it will start breaking down the whole apparatus. So here we are, most of our patients are normal patients, sedentary humans, sedentary lifestyle. So when you get to this stage, they can do squatting. You've started introducing front lunges. After some time, they will tell you, I can walk, I can go to work, I can sit down, I can stand up, I'm not using any walking aid, I'm not coming again. That's what the feedback you will get. So, but you make sure that at least there are criteria for discharge. Then we go over to patients that mostly, this one is recommended for a sports person. So when you hear that a footballer is out for Achilles tendon rupture, and they will stay for 4 or 3 months, immediately after the surgery, they will have to undergo a certain level of rehabilitation. Then there are criteria to tick off before they can return to. It applies to hip replacement. If the person is engaged in low impact exercise, low impact sports, such as skiing, such as swimming, such as cross country cycling, those ones, they need regimented exercises that will take them back, which you will have to use an outcome to ascertain this, an outcome measure to ascertain that this patient can go back to this level of exercise again. Again, once you've reached this level, you are actually talking about strength now. You are talking about endurance and proprioception in most of their cases. So you are now calculating, okay, this patient can do 1,000 reps as of yesterday, where the patient can do 800. So this one boils down, this level boils down to increased resistance, increased strength, increased endurance, and the proprioception. So I listed some criteria for discharge. It applies to either a sedentary life patient or moderate exerciser, but there is a little bit addition when you talk about advanced. But these are the criteria for discharge from a physiotherapist. You have that the patient cannot walk with any antalgic gait. It may not even be antalgic gait, but any gait, abnormal gait, Trendelenburg's gait. You can do the Trendelenburg's test to ascertain that. Then independent in-step over step staircase climbing. We have a way to do that here. You watch the patient, you can take record, you watch the patient and look at it and ascertain that. When active range of motion, when the patient can actually raise their leg up in all direction and there is no pain, then you take your GMP, the patient should be 4+ or even 5 at this instant. Normal age appropriate balance, proprioception. Compared to how the patient was. Again, that's why assessment is important. How was this patient before? How was this patient living before the patient presents with the case? Then independent home exercise. This patient undergoes exercises at home. They can do all that you've listed out without you being there. You will check. You will have to check, tick it off. What can this patient do We have programs that based on the goal established and based on the purpose why the surgery was done. So like I said, the summary, early and timely referral of patient gives better outcome in a hip arthroplasty. Pre-operative assessment of patient still gives better pre-operative assessment and sessions play important role in the outcome of hip arthroplasty. Patient education is very important. You are educating, the physiotherapist is educating. It starts from the time of assessment. You are assessing patients, you are going to undergo hip replacements. Make sure that the patient understands that he will do rehabilitation, which will take not less than 6 weeks to be able to work independently. Because sometimes we don't explain to patients what this entails. So what do they do when you're done with the surgery? What do they say? I thought by 2 weeks or I'll be flying. No, you won't fly in the next 2 weeks. You have to take them through this. Tell them, be realistic with their goal. This is what we are expecting you to do based on your assessment, based on what we discover. When my patient who is in the ward now said, I will walk out here with crutches, I say it's possible, but let me tell you what we have to do. You are undergoing revision arthroplasty for 2 hits. So if we are going to do this, it's not, I will not do physio today, I will do the next day. Your case is not the same thing with your roommates that had undergone only one, the first stage, one stage hip arthroplasty. It's not the same. This patient came in here walking with a limb without even support. You came in immobilized on wheelchair for the past 1 year. So your performance with the other patients will not be the same. You break it down, but we are not saying that you cannot walk and function better. We are saying that you have to undergo rehabilitation, timely rehabilitation, because if there is playing about it or skipping it, we will not get the results we want. It takes time to build up muscles and it takes time to get the strength. Then finally, MDT approach, which focuses on patient-centered care, still remains the best option. If you have a plan to do the surgery and you think that this is a case where you have to call in a physiotherapist and say, please help me assess. Let's know what is happening and what we can do for this patient. Of course, you will do the surgery. My side is just the rehabilitation, so that the patients will understand that, see, you can't even, I'm giving you one kg dumbbell, you can't carry it, you can't take it up. So the patient has to understand that you must undergo rehabilitation sections, you must be faithful to that before we can achieve the purpose. Thank you. And this is my reference. Over to you, Dr. Kemi.
Thank you very much for that lovely presentation. It's nice to know that no pain, no gain has left Physiolingo, because I remember walking into a physio gym. I don't know if they still have that sign up now, but those who know. No pain, no gain was the first thing I saw, and I'm like, God, I'm in trouble. So I wonder if there are any questions from members of the house. Yeah, so you can unmute yourself if you have any questions, or you can type them into the chat box. I have a few questions myself, and perhaps I'll just start off with that while waiting for other people to comment and pop in their questions and so forth. I was going to ask you that what are the things you prefer for you prefer to have us include in the referral to physio? What are the details that you think are most helpful for you in terms of sending a patient for? What do you want to know from a surgical perspective that would help with rehab? That's one. The
Okay.
other thing is, are there preferred surgical approaches? Are there approaches that you think, okay, with this approach, rehab is easier if you can use this approach, or with that approach, rehab is a bit more difficult? Are there peculiarities with regard to how the operation was done that, from a physio perspective, if you could influence it, may sort of, change how you feel in terms of the ease with which the patients can get back up? And what are the appropriate sports and games then that you think, we can say, oh, after having good hip replacement on one side, no problems, the patient can go back to 1, 2, 3. Yeah,
Okay. Should I go on?
please go ahead.
Okay. The first question you asked is about again, not the surgical preference, right? The surgical procedure preference.
No, the first question I asked was, what are the details in terms of writing a referral?
Okay.
What do we need to tell you about that would make it useful for you to be able to rehabilitate the patient better?
Um, the okay. When we are concentrating, number one is looking away from the hip, looking away from the hip. What is the grip strength like? The core, the patient's core muscles. What are they like? Like you can signify, or you can actually make a small note on that. This patient has been mobilized on the chair for, I don't know, for maybe a year. The cores are weak. The upper limb, the grip strengths are weak. We can take it from that. Then the range of motions, we can measure. We can measure range of motions at the joints, even the hip, so that we can deal at this particular range. The patient is in pain and all that, so we can take it from there.
Okay. And do you have any preferred surgical
Yeah, yes, there are some things you can, the surgeon, if we are working on a patient who doesn't have any comorbidity, no complications from other surgery, direct anterior approach and direct lateral approach has been always, because the two, they've been the best option, because one, they avoid compromising the hip abductors, and Trendelenburg's gates will not be something we will have to deal with post-operative.
That's interesting because I know they say the true hip surgeons love their posterior approach because of revisions. But I
Yes.
see your point.
For revisions, yes, for revisions, those are the ones we can. I'm talking about if we have somebody that doesn't have any issue. But when we talk about revision, we can work with anything, because at that point is to get the patient to have a good hip. So every other thing becomes second.
Uh-huh. And what are your preferred activities in terms of sports and games after rehab?
Swimming is a good a way to work on the hip. Swimming, then exercise is brisk walking. We're not talking about high impact here. Normal activity, walking around, taking a walk every day. We don't advise so much on jogging, because again, it puts pressure on the hip, the replaced hip.
Having said that, we Nigerians were land animals. Many of us don't like water at all. Because every time I tell patients swimming, they look at me like, seriously? And even I can't swim. So I feel a bit silly, you know, prescribing something that I know I can't do either. So are there things that we can do in our own environment apart from walking and maybe
Well,
golfing, which is for the big boys? Simple
yes,
exercises that people can do safely.
yes. We group golfing as low impact sport, so it's okay if the patient can. It's part of what is recommended, even for a golfer. It's fine. Then there are regimented exercises inside the house, which has to be planned for the patient. There are regimented anaerobic exercises the patient can undergo and do at home.
Do you then routinely discharge your patients with these? Because I know a lot of people have problems with even walking because the roads are not always safe where they live. They're afraid of kidnappers, like one woman told me, and so on and so forth. So, do you then routinely discharge everybody with a set of home based exercises for?
Here in Cedar Crest, we do. Even we have a protocol that even if you are not based in Abuja, we can give it to the physiotherapists. That we call it the HIP protocol for to continue with the program, because people come in to do the hip replacement and go back. So here we do. And it's mandated for every physiotherapist here in Cedar Crest to give patients home program as you are discharging them, with an appointment of maybe a month or 3 months to a follow-up appointment to know how the patient is doing.
Okay. Thank you so
Yeah.
much. There are a few questions in the chat box. Do you want to read them yourself or would you like me to read them out?
I'm looking at it. What is the difference between isometric and isotonic exercise? Isotonic exercises are exercises that involves increase in length of the muscle and the moving away from the points where the exercise is, the stretching of the muscle fibers. But isometric, you have just contraction, but there is no increase in length. So basically, when we have patients that are in pain and you don't want them to, and you know that this movement is going to cause pain for them, you put them in isometric exercise. It's contraction of the muscles, but there is no increase in the muscle fiber or in the increase in length of the muscle fiber. So that's how do you rehabilitate a patient with girdle stone arthroplasty since there is no femoral head? If there is no femoral head, there should be something there. If is revision, hip replacement, revision, there is spacer in most cases. I don't know whether I'm answering this question right. There is a spacer there attached. You don't actually put weight on that. What we do is we just try to work on the muscle and wait until there is the second stage is done. The person that asked the question, did he help?
Yes, I'm with you.
Okay. So what we actually do is just we keep the patient and at isometric level of exercises, waiting for the second stage to happen. The patient can be immobilized on wheelchair. If it's a younger person, he can walk without weight bearing. That alone is helping. The muscles are working. And if we have HBSS patients, we found out that their muscles are shortened because they have to do trick movement to avoid pain. What happens to most of them, their hip flexors become shortened. You see, then their strides in the gait circle is reduced. What do? You have to find a way on how to stretch out this muscle, make sure that that they are not in pain, but you stretch out these muscles because it will actually increase their strides when they start walking better. Which early ambulatory device is preferable after a hip surgery? Whole Zimmer, whole walk, Zimmer walking for. This depends on the patient. We have young people that can walk after hip replacement on bilateral axillary crutches. But like I said before, if you are dealing with an elderly patient, you don't risk fall by giving them bilateral axillary crutches. They are not going for Olympics. They are not going. What they want them to do, most of them, is for them to be able to move from point A to point B. Zimmer frame is fine. How do you manage them at home in view of possible, low toilet seats? We have what we call commode. It's actually is included in our pamphlet. Commode that comes with the chair. We have the detachable commode. Then we have commode that you can, detachable commode is actually one, but different types. So you attach it to the chair, attach it to the toilet seat. If the patient sits, it puts the hip at a higher flexion level when compared to the knee. I hope I've been able to answer some questions.
Thank you. I wonder if there are any other questions. And speaking of fall assessment, do you have like a specific fall assessment tool that you use for your patients?
We do. We have outpatient. We have fall assessment tool. You will now ask how many times do we utilize it, but we use it more for amputees. But we do actually, we do. Here, we customize one to use.
Okay.
Yes.
I wonder if there are any other questions or comments. And in the meantime, you told us that we've gone from rice now to peace and love. And honestly, we are still stuck in the bit of rice. So in fact, we now added P and made it price. Then somebody puts R at the back and made it pricer. So I was just going to say, could you please give us like a bit more of clarification on this new?
That's a whole lecture on its own.
Sorry. The summary then.
The summary for the price.
Yes.
Or the summary for
the
piece. Well, the peace and love, so many research have found out that the eyes does not do much for acute injury. And in this case, we are seeing surgery as an acute injury to the hip. It doesn't do much for that. It's just old practice. So it's even the same person that started the rice that reviewed it to price. Then we now came to the point of peace and love. Peace and love, P is protection. This is for just acute injury. I'm not talking about the hip replacement now. E is for elevation. A is avoid anti-inflammatory steroids. C is compression. Then E is education. You educate the patient. Then and the load, you start loading the joint, the muscle gradually. Optimization. Then V is vascularization. Then the E is returning to the normal exercise.
Sorry, I'll make you go over that again. So you said protect, elevate.
Yeah, avoid anti-inflammatory.
Avoid anti-inflammatory. So all these NSAIDs are out.
And the NSAIDs are out.
That's
Compression. I know. Compression works a whole lot better than putting ice. Compression works a whole lot better. Then you educate the patient.
Okay.
When you, yeah, then the loading, then gradually you start. When we say optimal loading, you don't load the patients with, when I say loading, it's of course activation of the muscle. You don't start with 5 kg when the patient has not done 1 kg. Then of course vascularization and the exercise. So that's how it's
Interesting.
interesting. Yes.
Okay. Thank you very, very much for that. I just put it in the chat box so that at least we can all, well, I can remember really. I'm sure there are people who already know
Okay.
about it. Me, I'm still in the Middle Ages. So if there are any other questions, any other comments, otherwise we can thank Isn't for her time and her commitment to our association. Meanwhile, from tomorrow, we'll be going into the core lectures on total hip replacement with Dr. Charles Ayekolue. We don't have permission to record them, so it would be nice for people to come on time because we still have our limits on the Zoom platform. I know there will be very in-depth sessions as he's a pretty experienced clinician and teacher with a couple of decades of work under his belt. Meanwhile, I want to thank everybody for coming. Isn't thank you very much for honoring our invitation. We look forward to your other lectures that are coming. From next week, we'll pop back to our hand lectures on Saturday as well, and then continue the HIP curriculum on Sundays. So see you all tomorrow for the first of the sessions on hip replacement, which will be on biomechanics and biomechanics with regard to hip arthroplasty. Thank you very much and see you all.
Thank you.